Just 1 second, I'm setting up my screen. Uh,
Screen is visible.
yeah, okay. So I'll be covering 10 questions on various topics. So, first question is, what is the WHO fourth movement of hand hygiene? I'm not talking about the steps of hand hygiene. I'm talking about the four movements of hand hygiene. So everybody can type your message in the chat box. So there are two different things are there. One is your hand washing steps are there, and second is your hand movement. What are the movements of hand hygiene? Okay, just few more seconds. Wait. Okay. So Alicia has written after touching the surrounding, and Dr. Jaya has told after, before and after touching. So these are the basic six movements of hand hygiene. So one number is before touching the patient, second is before any clean or septic procedure, third is after body exposure of any fluid which is risky like blood, any secretions are there, urine, stool, anything is there. Fourth is even after touching the patient, and fifth is after touching the surrounding. So partially right, not completely right, but still that's fine. So these are all the important steps of hand hygiene. See, for NICU, the most important thing is hand hygiene. If you do a proper hand washing and if you follow the steps of proper hand washing, then the chances of sepsis decreases drastically. So the major morbidity in on all the NICUs is about sepsis. I think antibiotics use is becoming so much rampant. So the only way we can prevent sepsis, the best and the cheapest method is hand washing. So, and when to do hand washing is that is also very important. So I am sure that, not sure, but at least I can say that nobody is doing it after touching the patient. So before touching the patient, yes, all are doing it, or at least before touching, doing any procedures, everybody is doing hand washing. But how many of you are doing after touching the patient? So if you don't do it, what is there that this bacteria can spread to the surrounding? Suppose you had gone to the patient after touching the patient, you had not done this, and you had immediately started your file work, you have received any phone, you have touched all the common areas. The bacteria has gone from that patient to the common all the common areas. So there are very high chances that next time before touching any other patient, somebody else might have touched that common area and then touched the second patient. So that this is how your bacteria are spreading. Okay, so this is a very important point. At least you should do proper scrub, this uh, Bactorub or any other. I'm not promoting any company, but at least any sanitizer use should be properly done. And again, in those sanitizers also, proper 6 steps of hand wash what you follow, you should be doing in a baby with the hand rub also. Okay, so now my second question is, okay, the second question is, in TPN, lipids are given, and the commonest lipid which we use is the SMOF lipid. Okay, so what is the F stands for? S is for soybean, M is for medium chain triglycerides, O is for olive oil, and F is for, okay, so the answers are coming fast. Okay, so it is fish oil. Great. So what is the dose, if anybody can type, what is the dose of lipids what we use in the babies? What is the dose of the lipid what you are using? 1 gram, 2 gram, 3 gram, how much? Starting dose. So that is the percentage. Yes, 20% is there. 2 gram. Okay. Dr. Virendra, Dr. Alisha, 0.5 to 1 gram. Rahul 1 gram, Aruna Devi 1.5 to 3.5 gram, Monica Vaidya has started 1 gram. Okay. So basically, yeah. So there is a concept of aggressive nutrition in which you can directly start with 3 grams. So it is not necessary you always start with 1 gram. Only thing is you initially you need fluid restriction is there. So unfortunately in India we are not having any pharmacist or pharmacy backups are not there in which out of India few of the good centers what they are having pharmacy backup. They come to your NIC every day morning, they calculate the dose and they make the preparations, and they have started the lipids at a higher dose also from the starting itself. So they concentrate the TPN, so over fluid volumes with proper fat content can be given. So you can start with a higher dose of lipids also and a higher dose of protein also, amino acid also. So how many of you monitor triglycerides? You can just yes or no. How many of you monitor triglycerides while giving fat? After 1 week, Alicia, okay. Vaidya, no. Okay, anybody else? If you are doing it, say yes. If you are not doing, say no. At least you will be interacting with everyone. So you will have a habit of doing an interaction and a habit of doing giving answers. This is the purpose of this thing. Okay, not using fat at all. Okay, Dr. Ruhi said yes, they are monitoring. Aruna Devi, no. Okay, so it is not necessary to monitor. Only few of the babies might require it, but as a routine, previously it was thought that triglyceride level should be monitored and dose adjustment should be done, but it is not necessary. So you should not be monitoring triglyceride in all the babies. Okay. Now the third question is ibuprofen dose schedule for closure of PDA. At what dose of ibuprofen do you give to the babies? 10 mg day 1, 5 mg 5 and 5. Okay. 10 5 5. Okay. Okay. So first day is 10 mg per kg. Day 2 and day 3 is 5 mg per kg. So there are out of India there are two preparations are available, oral and IV. India initially IV preparations were not there, but nowadays 100 ml packs of injection brufen are available. So you can try them. Again, GI side effects you will have to monitor. So what is the other two drugs I would say for closing of PDA? What are the other two drugs which we use for closure of PDA? Paracetamol, PCM. Any other drug? Yes, indomethacin, very good. Okay, great. Okay, PCM, paracetamol, and indomethacin are the two other drugs which we can use. Again, indomethacin IV preparation was initially available, but not available right now, easily not available. Paracetamol, both routes you can give, oral as well as IV preparations you can give. Okay. So fourth question, name the condition of the twin and it is common in which type of twin? Okay. So majority have given it correct answer. It is twin to twin transfusion syndrome and it is common in monozygotic twin. So what are the complications in this baby? What complication you will get in the baby with polycythemia or the baby which is more red, and what are the complications which you will get in baby which is more white? So they are labeled also. Twin 1, what is the complication? Polycythemia in twin 2. Okay. Twin 1. Okay, anemia. Okay, any other? Polycythemia and anemia are the obvious things. Any other complications? CCF into, okay. Okay. IVH, okay. Hypoglycemia also. Okay. Now, fifth question is identify the device and what is it used for? Okay, 10 more seconds. Okay. So, Dr. Jay is the right answer. It is NIRS. It is near infrared spectroscopy and it is used to measure the tissue oxygen delivery and the consumption. So, in babies with HIE, we will come to know whether the baby will how much oxygen consumption is there and how much tissue oxygenation is being delivered in this baby. So, it is not an EEG machine. So, in EEG machine, electrodes are applied directly over the scalp, but this is an NIRS machine, that is near infrared spectroscopy machine. Okay. So question 6, what does the arrow indicate? So this is a graph which we see in an ventilator. Okay. So what is happening in this baby? Any other name for this? Okay, good. So Dr. Virendra, as Dr. Monica, Dr. Soumya, so everybody has started giving the correct answer. It is auto peep. So what do you need to do in this babies then? What is the, how will you manage? So you are getting an auto peep. Your expiratory wave is not reaching up to the baseline. Okay. So everybody is saying E time has to increase the E time or reduce the rate. So what is happening that before your expiration is ending, your inspiration has started happening. So what is happening that there is no complete exhalation is not happening. So in these babies, there can what all complications this will lead to. So the amount of air that is entering into your lungs is not able to completely come out. So what will happen? Yes, air leaks, pneumothorax. Yes, very good. Okay, so you can increase the TE expiratory time in these babies so that the baby is able to completely exhale. The dotted line is the ideal graph, what should be happening in these babies, not the dark line which is occurring in these babies. Okay, so it is an auto peep. Question 7, what is the name of the diagram? And what is the, how do you, at least you can give the name. I will explain it to you what is, how do you, importance of it. What is this diagram? Yes, forest plot. Okay, good. So yes, great. It is a forest plot. So yes, to sum up the meta-analysis. So this central line is the line of no effect. So we what is then randomized control trials are there in which a meta-analysis is done in which there are multiple randomized control trials are gathered when their results have been matched and similar results have been plotted. So below this, there is a confidence interval is there. So if it is going on the left hand side, it favors whether if you are giving whether surfactant improves the outcome in RDS or not. So if it is on the left hand side, then it says that it improves. If it is on the right hand side, that means it favors the control and it is not required. So center part is the square which represents the treatment effect. Median of it is there, and these are the variables. The confidence interval is just one second, is shown by the horizontal line, and there is a below there is a diamond is there which shows the pooled effect of all those studies. So if it touches the central line, then that means that it is inconclusive. If the diamond is completely either of the it is on the left side, that means that the chart this study favors the this thing intervention, and if it is on the right hand side, that means it favors the control. That means that it is not useful. If it is on the left hand side, that means surfactant is beneficial for RDS. If it is on the right hand side, it is not beneficial. And if it touches the midline, that is the line of no effect, that means that it is inconclusive, that still further studies or are required to decide whether this intervention is useful or not. So this is a forest chart. Commonly, you see this in the Cochrane studies. They all the interventions have been done, and those are being plotted against the forest chart. So you should be knowing this chart and how do you interpret it. That is the median. Then there is the confidence interval. Then the size of the square. Also the how many this thing are there. The size of the square is the proportion of the relative weight of that study. So how many intervention groups are there in this study or not, those are being depicted. Okay, so this is a forest plot. So it is shown as a logarithmic scale when the line of no effect is at 1, on linear scale when the line of no effect is at 0. The squares represent individual treatment effects and the diamond represents the pooled effect. The width of the diamond represents the 95% confidence interval. If the diamond crosses the line of no effect, the meta-analysis does not significantly favor experiment or control group. Okay. Now question 8. Which was the drug which was studied in the Premeloc study to prevent BPD? Okay, 10 more seconds. Okay. So few have told hydrocortisone, few have told about dexamethasone, but the study in Premeloc study, hydrocortisone was studied. It was an early intervention, early hydrocortisone that has to be started in the first initial 7 days. So hydrocortisone was given and the effect was shown. So how do you decide when to give hydrocortisone in which babies? So NICHD website is there in which there is a scoring system for BPD. So if the score is more than 60% in the babies who are having BPD, then you decide whether you want to give an early intervention therapy to the babies. Dexamethasone trials were done, but it has been stopped early because of the side effects. So dexamethasone is not to be used in early group. So this is a prophylactic treatment for prevention of BPD. This is not a treatment of BPD. It is for the prevention of the BPD. So there are various parameters are there, whether how much preterm the baby is, what day of life it is, then whether antenatal steroids were given or not, RDS was there or not, baby required ventilation or not. All those intervention, all those data have to be fed into the website, and then it will give you a score. So from based on that score, you decide whether you need to give the steroid to these babies. Only drug which has been studied and has shown some beneficial effect is hydrocortisone. Again, I'm telling it, dexamethasone should not be used. So an early intervention therapy is a prophylactic treatment for prevention of BPD only in babies who are at high risk. So what are the drugs which are used as a late drug? So one is dexamethasone, is the commonly studied, and which is the commonest protocol which we follow for giving dexamethasone. Okay, yes, that regimen. What is the dose and how much? What is the duration? Okay, so Aruna Devi has told 10 days, yes. It is a tapering dose, yes. So what is the full form of that? DART. Is it a name of some person, whether it is an abbreviation? What is it? What is the full form of that? Yes. Dexamethasone, a randomized trial. Yes. So that is the full form of, so 0.89 mg of a total dose given over 10 days duration has to begin. Any other drug which can be used? One is hydrocortisone, one is dexamethasone, any other drug? Prednisolone, yes. So even trials of oral prednisolone have been done. Okay. Okay, fine. So the ninth question is identify the marking and what is the clinical significance? Does it signify is there a good prognosis or a bad prognosis? Yes. So it is a portal vein gas. It is being seen in the babies with necrotizing enterocolitis, and it shows a poor prognosis. So why does it happen? Why it is there is there? Why the air? How does the air reach over there? So basically, the bowel becomes starts getting necrotic. So there is an air gets collected inside the bowel wall. From there, it enters the blood vessels, and from there, it can go up to the portal vein. Okay, so this is how you see, and it is a bad sign. Long-term prognosis and all those are a bit bad in those babies. Okay, so last question is, in which view of the cranial ultrasound you see lady in dress appearance? Is it normal? Is it abnormal? Okay, great. So it is lady in dress view. It is a true sagittal midline view. Okay. So it is a exact true sagittal view. So from this you decide that right now you are in a exactly in the midline. From that you can decide whether the baby is you decide the side, which is whether there is a left side or right side. So at least in this is exactly in the midline. Okay. So lady in dress view, it is suggests that it is exactly in the center. Okay. So what is this structure? These two parallel lines. What are these two parallel lines? Yes, corpus callosum. So from the mid sagittal view, you can see the corpus callosum and you can identify whether the baby is having corpus callosal agenesis or not also. Okay. So this is it. These are the 10 questions. Thank you so much. Over to Dr. Deepan.
Thank you, Dr. Kunal Bhai, for excellently moderating the OSCE session. It was highly interactive. I thank Dr. Mohit Sani sir and Dr. Kunal Ayya again for excellently moderating the session of the case presentation by our fellow students. Dr. Mohit sir, is he available? Okay, so I think we can officially close this session. Good night, everyone, and best wishes of the Diwali, because festive seasons are about to over. Again, thank you everyone for being present.
Thank you so
Thank
much.
you.
Thank you, sir. Thank you. Thank you.
Thank you, Sarita. Thank you.